Good afternoon, everyone. I see the numbers are going up. We will begin in 2 minutes. If you could please share your name, and well, your name will show up, but your location and your role in community. We'd be happy to see that. And we will just begin in one more moment. Thank you for your patience, and thank you for attending the Maternal Infant Health Series. Good afternoon. My name is Nicole Fernandez, and I'm the project manager of the Wayside Recovery Maternal Infant Health Series. We'd like to thank you for joining us today. We will be hearing from Ellen Jirik and Christian Mentor. Our topic today is Beyond the Birth, Patient-Centered Care in the Fourth Trimester. We'll be discussing and sharing refining postpartum care as an ongoing individualized process that ensures healthy outcomes for birthing people and their families. This Project Echo Series extension is a movement to demonopolize knowledge and amplify the capacity to provide best practice care. Wayside is committed to assisting, being a part of the conversation, and leading change in maternal infant health outcomes and addressing the disparities. We are happy to partner with Minnesota DHS and the SOAR 2 SAMHSA grant, which is the SOAR grant stands for State Opioid Response Grant from the Substance Abuse and Mental Health Services Administration, SAMHSA, and the Minnesota Department of Human Services. Nothing in this materials constitutes a direct or indirect endorsement by SAMHSA or Minnesota DHS of the content or services or policies. We look forward to hearing from Christian and Ellen today, and I'd like to turn it over to them at this time. Thank you, everyone, for joining, and we are recording this series presentation today. Thank you so much.
Thank you, Nicole. As Nicole has mentioned, we will be talking about postpartum health, what is called the fourth trimester. And so just for a quick outline of what we're talking about, we're going to define what the fourth trimester is, talk about some background information about the state of postpartum health, and then walk you through some steps and solutions for how you could potentially redefine what postpartum care should look like going forward. Do you want to introduce ourselves in any way, Ellen? Or?
No, I'd be happy to do that. Okay. I apologize. Yes, I'm sorry. I'd like to introduce you to Christian Mentor, who is the manager of maternal and infant health initiatives from Nebraska and Western Iowa. Prior to joining the March of Dimes, Christian was a medical librarian providing research support for health professionals and patients. She is passionate about achieving health equity for all birthing people and their families, and is excited to be in a position where maternal and infant health is now her daily work. She received an MS in Library and Information Science from the Catholic University of America and is currently pursuing a master's degree in public health at the University of Nebraska's Medical Center. Christian lives in Omaha, Nebraska with her husband. Welcome, Christian. I'd like to share a little bit about Ellen Jirik. Ellen is the manager of maternal and infant health initiatives in Minnesota for March of Dimes. She attended Smith College and graduated with a degree in history and Latin American studies. Subsequently, she spent time working in international development in Nicaragua, Bolivia, and Brazil. While in Latin America, Ellen was able to focus on community engagement and public health, executing many community and volunteer-led projects. She is fluent in Spanish and Portuguese. She now resides in St. Paul with her partner and her 1.5-year-old daughter and 3 fur babies. And I overlook that Ellen is went to school in my hometown, which is Boston, Massachusetts, and I'm a big fan of women's institutions. So welcome both Christian and Ellen.
Thank you. All right, so I'm going to kick it off and let's talk about what is the 4th trimester. So the 4th trimester is a 12-week period of transition after birth. Mothers and birthing people are especially vulnerable as they experience challenges related to physical recovery, hormonal changes, mood disorders and anxiety, and adjustment to social support and connection. The collective health of both the birthing person and their baby are very important, and caring for a newborn are critical. This concept of 4th trimester also moves us away from viewing the needs and experiences of birthing people and babies as separate. The needs of both must be considered in context. Now, in today's presentation, we will be focused a little more on the needs of mothers and birthing people, as there are gaps in our current systems and opportunities to provide more tailored and person-centered care. And while today's conversation is more focused on the 4th trimester, it's important to note that full recovery from birth may take up to a year, and the postpartum needs and health risks can continue throughout that time, throughout that 12-month period. So let's talk a little bit about the current state of postpartum health. So for many years, standard postpartum care has been 1 6-week postpartum checkup that's often viewed as a clearance to resume pre-pregnancy lifestyle. It's more like a checklist of everything looking good enough and then see you later at your next well woman's appointment next year. And that's if the patient even already has consistent pre-pregnancy preventive care. And so women and birthing people go from frequent appointments during pregnancy to typically 1 visit 4 to 6 weeks after birth. And so that approach of a single encounter leaves a gap of maybe not being able to get access to care as soon as they need it. Many birthing people are navigating weeks of postpartum transition on their own. And as they are dealing with different changes with their body and with their health, they may not always know who to reach out to or where to go for assistance. And the majority of postpartum ER visits and hospital readmissions often occur within the first 2 weeks after birth. So that's before most birthing people would have made it back to the OB/GYN's office for their postpartum visit. And even with those that, even with the more traditional form of postpartum care, 40% of women don't even attend that postpartum visit. And so there's a gap in care for a lot of different reasons. Some may have challenges with childcare, with scheduling their appointment, with transportation, or returning back to work early. So there may be a lot of life events that interfere with that. And so even with the care that is offered, there are a lot that are missing out on opportunity, health education, for support and guidance as they handle the postpartum period and the different transitions. We also see that postpartum care is often fragmented among different providers. So birthing people may need, their obstetric care, they may need mental health care, they need physical therapy, they may need lactation support, and pediatric care for their newborn. And so all these different providers are often maybe in different offices, they may be in different healthcare systems, and oftentimes they may be left up to the birthing person or their partner to help navigate in making the appointments, asking for referrals, asking for assistance. And so that fragmented approach to care also leaves some gaps in birthing people knowing their options should be or who their support people should be. There's also often inconsistent communication for transition from the inpatient to outpatient care. So once they're discharged from the hospital, there may be some gaps in the communication as far as what the warning signs should be for their health and well-being as they recover from birth, following up with those additional appointments or knowing what the resources are in the community. And there could be also disconnect between medical practice and the personal experiences of birthing people. So sometimes the preferences and choices and values of the birthing people and their family are not always taken into account. And so some of the information they receive feels like they're being told what to do instead of being included as part of the process and a part of the decision making. And then there's often a lack of consistent public policies to support postpartum care. So even outside of the clinical environment, lack of consistent family and medical leave across the US, not everyone has access to that resource. Not every state offers 12-month postpartum Medicaid coverage. And the reason why that is important is we know that in the US, nationally, 43% of births are insured through Medicaid. And that percentage may be even higher, some states even higher. So for example, here in Nebraska, about a third of our births are covered by Medicaid. But if you look and break down the data by race ethnicity, then we see for our state, Black and Indigenous moms are insured through Medicaid at higher rates, so 60 to 70%. So for those that are depending on Medicaid for insurance, policy options that provide ongoing insurance is crucial, and not everyone has access to that. There are many postpartum health concerns. So one being maternal death from complications of pregnancy or childbirth. The most recent report from the CDC, I believe there were 361 maternal deaths in 2020. That was an increase from the previous years. So we're trending in the wrong direction with maternal mortality. And maternal deaths can occur up to a year after birth. And we'll see a little more information about that on the next slide. And then severe maternal morbidity are those unexpected outcomes of labor and delivery that result in significant short or long-term health consequences. So these are health complications that don't lead to death, but they're very serious and they can have long-term implications for recovering from birth and during the postpartum period. And so we see the severe maternal morbidity occurs much more frequently. So, 161 deaths, it's estimated that for severe maternal morbidity, for every one death, there are 50 to 100 severe maternal morbidity cases. So those are so many more women experiencing those situations. And then there are perinatal mood and anxiety disorders, which is the most common complication of pregnancy. And that can include depression, anxiety, post-traumatic stress disorder, obsessive compulsive disorder, and in rare cases, postpartum psychosis. And this can, any of those disorders can impact daily living activities of the birthing person, their ability to relate to their family members, and their ability to bond with their newborn, which can also affect newborn development. And then many women and birthing people come into pregnancy with pre-existing chronic health conditions. And so in the postpartum period, they also have to continue to manage those chronic conditions in addition to their health related to pregnancy and childbirth. So when looking at data on pregnancy-related deaths, the majority of those deaths occur during the postpartum period. So on the left side of this pie chart, you can see the breakdown of deaths by time periods during postpartum. 18.6% of deaths occur within the first week after birth, 21.4% of deaths occur from week 2 to week 12, and 11.7% of deaths occur after the 4th trimester, up to 365 days after birth. So we do see that the highest concentration of postpartum maternal deaths occur during the 4th trimester, during those first 12 weeks after birth. However, it's important to note that there are still health risks, even up to 1 year post-birth. So the continuity of care is crucial. We also know that timing affects the cause of death. So the leading causes of death change depending on whether it's during pregnancy, on the day of delivery, or a different time frame during the postpartum period. So on this table, we see that on the day of birth, for example, the leading causes of death are hemorrhage, amniotic fluid embolism, and a category of other cardiovascular conditions. However, by the first week after birth, we see that hypertensive disorders and infections become leading causes of death along with hemorrhage. And then later in the 4th trimester, we have other cardiovascular conditions and cerebral vascular accidents, which are strokes, along with infection. And then, after 43 days post-birth, we see that cardiomyopathy and other non-cardiovascular conditions and cardiovascular conditions are leading causes of death. So we see the maternal health risk shift and change as birthing people transition through different stages of their postpartum recovery. As I mentioned earlier, severe maternal morbidity includes those cases of significant complications that don't lead to death, but still have very serious implications for short and long-term health. Most research on severe maternal morbidity, or also known as SMM, has focused on the time period during hospitalization after birth. So we don't have as much comprehensive data on SMM cases that are newly diagnosed after a birthing person has been discharged from the delivery hospital. But I wanted to highlight this results from a study published in 2021. It included a national sample that included women with both commercial insurance and Medicaid. And what they found in their study was that 1 in 7 SMM cases were first diagnosed after the initial discharge from the delivery hospital. And for women insured through Medicaid, it was 1 in 6 cases. And among those cases diagnosed after discharge, 75% of those cases occurred within the first 2 weeks after discharge from the hospital. So in most cases, it's probably happening before mom and birthing person had the opportunity to return for a postpartum visit with their OB/GYN. And most SMM cases after discharge were related to infection, cardiovascular factors, such as sepsis, pulmonary edema, or acute heart failure. So in this study, there were some limitations on data related to race and ethnicity. They were able to disaggregate the Medicaid data by race and ethnicity, but not the commercial insurance data. So among the Medicaid population, they did find that Black women were 1.7 times more likely to have their first SMM case diagnosed after discharge from the delivery hospital, compared to white women who are more likely to have their case occur while they were still in the hospital. So more research is definitely needed in this area, but it helps to shed light on why effective care is so important during the 4th trimester. And then perinatal mental health disorders, like I said, are very common as a complication of pregnancy and can occur at any time during that 1 year postpartum. We know it's estimated that 1 in 8 women experience postpartum depression, and it's estimated that 1 in 5 women experience postpartum anxiety. And then among fathers, at least 1 in 10 fathers experience postpartum depression, but for those that have a partner that have depression already, that increases to 50%. So if the mom has postpartum depression, then the fathers are at a risk of up to half of them also experiencing postpartum depression. And mood and anxiety disorders, although they can occur at any time during the postpartum period, there has been some peak periods identified for depression. And postpartum mental health disorders are definitely treatable, and families benefit from standardized screening. Current guidelines state that both parents really should be screened during the prenatal, the postpartum visit, and then up to 6 months through well child visits. And we also know that there are some inequities in the experiences of postpartum health complications. Black and Indigenous women are experiencing the heaviest burden of complications and adverse health outcomes. So we know that Black women are more likely to experience higher rates of maternal mortality and severe maternal morbidity compared to white women. They also have a greater proportion of late maternal deaths. So maternal deaths that occur after the 4th trimester and that 43 to 365 days postpartum. And they have different leading causes of death. Most of their leading causes of maternal deaths are related to cardiomyopathy, hypersensitive disorders, pulmonary embolism. And then, as I mentioned before, we saw among the Medicaid population, that particular study, there's first-time diagnosis of severe maternal morbidity, more likely to happen after hospital discharge. They're more likely also to use emergency room for care in early postpartum period. More likely to have symptoms of postpartum depression and anxiety with less access to treatment. And then report delays, more likely to report delays in provider care or provider dismissal of their health concern. And when talking about health inequities, it's important, and by race and ethnicity, it's important also to notice that this is not about biology. We know that race is a social construct. It's something that has been designed by humans to categorize other humans. And experiences of Black women are that way because of their experience of living out and dealing with racism and oppression, and how those structures impact their daily life. So it's just important to know there are differences in outcomes, but it's not because of genetics and biology in this case. And we don't have as robust data around some of the experiences of Indigenous women with maternal health outcomes, but we do know that they have higher rates of maternal death and severe morbidity compared to white men, 2 to 3 times higher for maternal death and 2 times higher for morbidity. And then they're more likely to have maternal death due to hemorrhage and hypertensive disorder. And Indigenous women also are more likely to report delays in care or provider dismissal of their health concerns. So I'm thinking about this background of like what we're seeing in postpartum health right now. There are opportunities for redefining what postpartum looks like and how to individualize that for the care of moms and their families, moms, birthing people, and their families. So before we talk about what that looks like in practice, I wanted to highlight the importance of respectful maternity care. So a woman or birthing person's relationship with their providers and maternity care system has a powerful effect on both short and long-term health and well-being. These experiences can be empowering, or they can inflict physical and emotional trauma. And the memories of how birthing people are treated during the perinatal period last a lifetime, and the actions that providers take can have long-term implications. So as we talk about patient-centered care in the postpartum period, we have to start with defining what does respectful care look like. And respectful maternity care is rooted in human rights. The precursor to guidelines around respectful maternity care are with the Universal Declaration of Human Rights in the 1940s, the United Nations Declaration on the Elimination of Violence Against Women in the 1990s, and then within the last decade, an organization called the White Ribbon Alliance and also the World Health Organization have published documents reasserting the human rights of women in pregnancy and childbirth. Now, most of the focus of human rights in the perinatal care has been focused on pregnancy and childbirth, and not so much in-depth discussion about the postpartum implications, but everything that has been outlined for pregnancy and childbirth is still applicable for the postpartum period. So I pulled some common standards that I saw across some of the documents that I wanted to share today. So I'm thinking about respectful care as a human right. So what that looks like is freedom from harm, mistreatment, and discrimination. So I highlight the fact that Black and Indigenous women are more likely to report delays in treatment, more likely to report dismissal of concern. So respectful care will look like a freedom from any type of abuse, any type of mistreatment, and any type of discrimination based on race, ethnicity, or gender. It also means the provision of information, informed consent, and respect for choices and preferences. That means that birthing people will have all the information that they needed, that they would be included in the decision-making, and if they have a disagreement with their provider or care team, that there be respect for the choices, preferences, and the values of them and their family. It's also important to have privacy and confidentiality, show dignity and respect, respect the autonomy and self-determination of the birthing person, and to provide timely, effective, and equitable healthcare. It's also important, as we talked about the changes in what postpartum health looks like as we transition to the different stages of the postpartum period, that there is continuity of care from pregnancy to postpartum, but also throughout that full year postpartum. as health and well-being changes. And also continuous access to family and community support so that birthing people and their babies and their families can reach the highest attainable level of health. Now, in 2018, ACOG did come out with new recommendations for postpartum care and what that should look like. And I'm going to pass it to Ellen to touch on this and then walk through what the critical elements of what a patient-centered postpartum care is, how it should be carried out.
Hi, everyone. Thanks so much for joining us today. So I just want to start with the current ACOG recommendations for postpartum care. Having contact with a care provider within 3 weeks of giving birth, if not sooner, depending on the situation. Ongoing medical care as needed, which means knowing your client or patient and knowing how often you need to check in. And then having a complete physical postpartum checkup no later than 12 weeks after giving birth. It should definitely be an ongoing process and should facilitate transition into that next phase of well person care. Next, Christian. Oh, next slide. Great. So there at March of Dimes, after a review of literature, surveys, community needs, 10 critical postpartum care elements that should be included in any sort of postpartum care program, continuum of care. It should include comprehensive content, fit within the continuum of care, be evidence-based and facilitate access, connect to resources, developed with a health equity lens in mind, incorporate mental health screening, monitor warning signs, patient-centered and facilitates connections as well as support systems, reflect different postpartum experiences, and employ multiple communication channels. So while there are many different elements in postpartum care, we can sort of put them into these 10 different boxes and break that down to be able to give some practical recommendations to put into your postpartum care today. So we'll start with includes comprehensive content. Next slide. So in a national survey, less than 1/2 of women attending a postpartum visit felt that they were getting enough information about postpartum. And this actually includes prenatal as well. It can really be as simple as telling birthing people what's going to happen to their body, what's going to happen postpartum, and starting that in the first, second, and third trimester, including it throughout the prenatal check-ins, right? As simple as you may experience pelvic pain, perineal pain, what's going to happen to your hormones, what is bleeding going to look like, so that none of those physical and emotional changes come as a surprise. So making sure you have comprehensive content, keeping it non-emotional, factual, culturally relevant, but also extremely complete. And then also to remember in a survey, majority of women or birthing people from all different cultural backgrounds would prefer their provider or birth worker bring up uncomfortable topics, such as sex drive, body odor, and different relationship issues they may be having with their partner. So it's important to be able to respectfully, kindly, gently ask those questions to check in with birthing people to see what's going on. Next. So it needs to fit within the continuum of care to be holistically integrated as a regular part of care. That means we don't start with postpartum care at the postpartum visit. Postpartum care starts in the first trimester, right? Preparing for life with baby, whatever that may look like. So beginning to create a postpartum team during prenatal visits is an excellent way to do that. Yes, it could be the provider, baby's provider, who's going to be dealing with lactation. Is there going to be a doula involved? Does the patient know how to have access to a doula? Like in the state of Minnesota, do they know that Medicaid reimburses having a doula? Do they understand the benefits of that? Is there home visiting involved? Do they know if they're eligible? Is that something they would like to explore? Who will be handling mental health? And who is their primary care provider? And if they do not have a primary care provider, how can that referral be made to transition into well person care in the future? The important part of this is whenever possible, a warm introduction should be made when making a referral or building this care team. The more that we can do face-to-face or in the moment, or make sure that we are giving them information, complete information, the more likely patients and clients are to follow through with building this team. Next.
Are you able to see the slide, Ellen?
Thank you, everyone, for your patience. Sometimes there's a lag. If everyone notices, just a lag. We're all in 3 different locations. So I still see evidence-based and facilitates access to care as the slide. Ellen, do you see connect to resources yet?
Oh, I do. I apologize, everyone. My internet here is not the best. So I appreciate your patience. And here we are on connects to resources. So does your system practice wherever you're working or working with birthing people have a way to help birthing people access community resources? Not simply know about them, but to actually access them, to make referrals, to explain what's going to happen when they access those resources and help walk them through that process. Does your patient know what a doula is and how to obtain one? Again, do they know about home visiting? Do they know if they're eligible, and do they know the benefits of home visitors? And it's normalizing conversation around life outside of medical components. Finances, food security, domestic relationship must be consistent, right? It can't be left up to your opinion of if someone needs something. These are standard questions that everyone is asked, so you can start the conversation around. These are common issues, and we like to check in with everyone about them. You know, are you worried about being able to eat this week or next week, etc. However your questionnaire would go. It is important to talk about all of these life elements, but again, we want to make sure that everyone feels comfortable and that it is standardized across all clients. Okay, next. Needs to be developed with a health equity lens. That means addressing our own implicit bias as well as implicit bias within our organizations, which of course applies to race, ethnicity, but implicit bias also applies to family structure, cultural practices, parenting style, weight, socioeconomic status. All of those different factors can come into play. Before that you can move forward, you need to address those within yourself and within your organization. And there are different ways of doing that, whether it is making sure that you have patient advisory councils, having your own workplace diversity and equity councils and groups that you're a part of, and or doing training and education on your own. Listen to the birthing person and trust that they know their own body. This is probably the most key. The birthing person is in charge. We are all guests at this birth. And what is going on, right? So when you are listening to them, don't only say you're listening, show your interest, make eye contact, active listening, repeat back to them what they've said, further the conversation. And then also importantly, through a health equity lens, what opportunities are you providing for reviews, feedback, and complaints, so that if there are issues where things do come up, that whether it's with you or with someone else or with the system, a patient is able to give that feedback and make changes. Next. Christian talked about this already. It must incorporate mental health screening, and postpartum international support suggests at minimum first prenatal visit, at least once in the second trimester, at least once in the third trimester, first postpartum visit, 6 or 12 months postpartum in OB or primary care setting, and then also at 3, 9, and 12-month pediatric visits. The screening could vary, but most people use the Edinburgh. Domestic violence screening is not necessarily only a mental health screening, but is a part of emotional well-being, so we'll include it here. Domestic violence screening is extremely important and should be done with the utmost care. There's a lot more information and resources out there in the postpartum practice bulletin with the 4th trimester project that can guide you through conducting that screening around emotional well-being. And then also making a plan in the prenatal for how a birthing person will make time for themselves postpartum. I don't even say self-care because I don't consider shower to be self-care. I consider that to be a basic human need, but it can be really hard for new parents to even take that time. So taking that time as a birth worker or provider to make a plan for how they're going to do that. Next. Monitors warning signs. Key here is empowering birthing people to know those warning signs, right? And ensuring that the birthing person and their support team also know what to do in case those warning signs appear. And emphasizing that complications are not the birthing person's fault, and so they need to be acted on immediately, and they need to be taken seriously, not only by you, but the entire team that is going to be dealing with that emergency. So educating from day one, what are the warning signs, what's going to happen, and how are we going to deal with it? And making sure that you are actively listening when someone says something doesn't feel right. Next. Patient-centered and facilitates connection. Again, this goes back to respectful care and shared decision-making. And around this, also making sure, I realized I cut out before, but making sure you make a plan, right? We have the plan for mental health. We have a plan for a postpartum care team. We need to make a plan around a support system, right? How is a partner involved? Is a partner involved? Family, friends, community, faith system or faith-based system. If there isn't a support system, are there resources that you can connect them to build a support system, and starting to do that early on so that we can build that village, as the 4th trimester project says, to make sure that you are not alone, and then also specifying each role those people will play in the postpartum plan. Next. Reflects different postpartum experiences. All birthing people need postpartum care. That includes those who experience miscarriages, those who experience losses. They need to check in and have postpartum care the same as those who have live births and continue, right? So everyone needs that. Also, 45% of birthing people will experience a traumatic birth. And I think it's important to emphasize that traumatic birth does not necessarily mean that the child is in the NICU, though it can. It can also mean having a childbirth experience that wasn't what you expected, being disrespected during the birth by hospital systems, staff, people in the room. It can mean a birth injury, requiring medical attention for you or for baby during birth, or it can mean a NICU stay, right? And NICU's parents should certainly be a priority for follow-up. They're often lost in the fray, and they're very isolated and often forget to take time for themselves, right? So what resources do we have to provide for those NICU parents and to provide for those different types of experiences? Social workers, is there birth storytelling workshops or trainings that go on within the hospital about how to tell your birth story for healing? Support groups, mental health support, March of Dimes, NICU family support person who focuses on supporting families through their time in the NICU.
Ellen, you cut out for a few minutes. I just want to add what she was saying is that March of Dimes has a NICU family support program that provides a lot of these resources through education and social support and things like that. Oh, are you back? All right, I'm going to, oh, I think you lost her. I think she'll log back in. Okay, I will pick up the next slide. The final step of the 10 steps is to employ communication across multiple channels. Oh, are you back, Ellen? So looking at utilizing telehealth for more frequent check-ins. So that not everyone may be able to make it in person back for a postpartum visit in less than 3 weeks. So there have opportunities. I mean, COVID-19 has shown us that we have so many opportunities for utilizing telehealth in more broad ways. So think about what methods can be used for follow-up for those that don't make it to their postpartum visit. So if you has not made an appointment or you didn't hear from them, what is your game going to be for follow-up to see what is going on and how you can support them. And then talk to the patient about what works best for them. So as Alan was saying, as part of that plan, during the prenatal period, you can talk about communication methods, like after the birth, how do they want to hear from their provider and from other members of their support team? Do they prefer app, email, the patient portal, a phone call? And then in addition to giving out information, there are also ways to improve the conversation between the provider and the patient. So think about motivational interviewing and how to open the line of communication so that birthing people and their families feel comfortable sharing the concerns and the questions that they have. Anything you want to add, Ellen?
No, I think the bottom line for all of these recommendations is make a plan, right? And talk about what's going to happen. So there are some really wonderful materials and resources out there from the 4th Trimester Project, from ACOG, that you could modify for your practice about how to talk through all these different elements and have a plan in place.
And then finally, we know that these are all great practices, and we all want to jump out there and redefine how we're providing postpartum care. But we know there also will be challenges in making that happen. I wanted to highlight a few common challenges that we know that healthcare systems or social service agencies may encounter in supporting birthing people, and then highlight a couple of solutions as well. You start, Ellen?
Yeah, so one of the major barriers in the United States is paid family leave. There's no federal family leave program. Some states do have it to success. But while there is 12 weeks of protected unpaid leave, most people are not privileged enough to be able to take 12 weeks or any weeks of unpaid leave. And about 4 in 10 US employees are not even covered by that. So in fact, only 17% of our entire civilian workforce has access to paid family leave. And of course, this prevents a lot of optimized prenatal and postpartum care in general. I mean, we know breastfeeding rates double when we have paid family leave. We know depression rates go down. And we know that a lot of patient-centered care is able to happen when we have that. So in terms of solutions, we can use our voices, we can advocate and participate to ask for paid family leave, not only in our states, but at a federal level. Also, payment models. Obviously, there are issues with fee-for-service. Pregnant people are not sick. They need a guide, right? They need to be guided through this process to know what's going on, check-ins, holistic integrated care. And so there is value-based payment, but there are still challenges when it comes to value-based payment. Studies recently have shown that incentives often aren't meaningfully around maternal morbidity, mortality, or racial equity, or health equity in general. So most of them are incentivized around what should be standard clinical care. And that doesn't see the metrics as big a rise in the metrics or those targets that we want to hit. And they don't really fundamentally change the approach to maternity care. However, it does engage providers in conversation and in quality improvement initiatives, which is really interesting. And there are opportunities to expand value-based payment systems to be more conducive to health equity and improved maternal outcomes, right? So changing those metrics and including more postpartum type care and more holistic overall prenatal to postpartum type care within those value-based payment systems.
And the next two challenges we want to highlight is the integration of care. So we mentioned earlier, postpartum care is often siloed and fragmented, and it can be a challenge for birthing people to access the different providers that they need in a timely manner, and to know how to navigate the healthcare system effectively. And so one solution for this is to offer a pregnancy care home model. And a leader in this movement has been the state of North Carolina. And you can see in some of the care settings they have developed is we have a teamwork between different providers, and you also have case management available to help connect the dots for patients between the different providers, to help with follow-up, to help with transition between providers, so that patients aren't left to do this on their own, and they have that additional support as they figure out the different aspects of their care. And so the warm handoff between providers and those referrals is really important and very crucial, especially in the postpartum period. Parents are dealing with fatigue, they're dealing with changes to their body, and they're dealing with changes to hormones and mood and things like that. And so the last thing you want to do is have to worry about introducing yourself to new providers or figuring out who else you need to add to your team. And so having that integration already and having those warm handoffs is key. And then with staffing, one way to address some of the health inequities that we're seeing is to diversify the maternity care workforce. So having more midwives, OBGYNs, nurses, obstetric care, but also community-based birth workers that represent the communities that they serve. They're coming in with that cultural knowledge already in place. They know how to approach their patients in a culturally relevant way. They may have the language expertise, the cultural expertise, and the community knowledge of culture and what their patients are experiencing with the resources and potential challenges or barriers in their built environment. And including more teamwork between the obstetric providers and the community-based birth workers. So knowing, as the providers, knowing who are the doulas, who are the lactation specialists, who are the community health workers that are already active in the community and are already trusted members of the community, so that you know how to connect them to the patients, how to refer your patient to them, who are the home visiting programs that are culturally relevant. And so that partnership between community and clinic is very important, because a lot of what influences health and well-being is what's outside of the four walls of the hospitals and clinics. So having those trusted community partners is very important. I think that's all for the formal part of the presentation. We do have a few more resources, but we're also open to questions if you have any questions for us.
Awesome. Thank you so much, Christian and Ellen, for excellent presentation. It is recorded, and we are happy that you have resources here. If you'd like to ask a question, please put it in the chat, and I will moderate. And then also Kate asked about, during the presentation earlier, she put in the chat, are the articles that support the mental health prevalence able to be emailed to us? So I believe it was something you referenced, Christian, if you could please share that with them. So we'll start there, and then I will monitor the Q&A or chat for any additional questions.
Yes, so we do have links to resources to support the data that we shared, and we have those links in the slides. So when we send out the slides, you'll just be able to look at the bottom of each slide and click on the link to access the resources.
Great, thank you. Would anyone else like to share a question or have a question in the chat?
And while we're waiting for questions, we can also highlight what these three resources are.
Sure.
I think Ellen had mentioned them already, but there's a toolkit from the American College of Obstetrics and Gynecology, their postpartum toolkit that's focused more on the clinical environment and has resources for the key components of postpartum care that aligns with their new recommendations for how postpartum care should be carried out. And then there are also postpartum discharge transition patient safety bundles from AIM, again, focused on hospital environments to help guide clinical staff in transitioning patients from inpatient care to outpatient care during the postpartum period. And then the fourth trimester project is more focused on families and resources for the families. So helps them understand education around postpartum health and what they can expect, and also some resources for, I think, some planning tools and checklists to help with that as well. Anything you want to add, Ellen?
Nope, those are all excellent resources, and definitely make sure to check them out and ask questions.
Thank you both so much for your wonderful presentation. This was definitely a topic I was very interested in, and I knew it was a need for our community in this work that we are doing. Additionally, the resources that you're sharing are extremely valuable. And then lastly, I was just in a community meeting this morning where some of the very things that you shared around care and support that's needed is critical. And I believe Minnesota very recently will be able to provide to Medicare patients a year after delivery to have Medicaid, and so that would cover their health care. So we know sometimes, as you shared, that is one of the barriers to health care and access, and so we're happy to be one of the states that has followed suit in recognizing that we need to extend that care for moms and family birthing people. So I know, Ellen, you're more local, and Christian, you're nearby. We appreciate you sharing your resource and contact information, and we just look forward to keeping this conversation going and continuing to network and share resources. The Maternal Infant Health Series will continue, and next month, it will be in July. I will place in the chat the link to register for the upcoming Maternal and Infant Health Series. We hope to see you all there as well. You can look on the Wayside link under the maternal health, infant health landing page, has all of the upcoming series, as well as we hope as we are networking together that you two will share speakers and other relevant topics that you would like to also see here as we are continuing this series. I'm trying to paste the link in. I'm going to stop